Hey, I'm going to go ahead and make some introductions before we begin our presentation. So glad to have you all here today on our Zoom programming. My name's Elena Dinkin, and I'm the Association Director of Forever Well for the YMCA of Greater Houston. As I've mentioned earlier to others today, I began doing the Zoom programming during COVID. And for many of you, this has become a great opportunity to connect with the YMCA from the comforts of your own home, to have that opportunity to learn and to engage. It has also been a real honor and pleasure to be able to work all these years with UTHealth Houston Neuroscience. Today, of course, we are very fortunate to not only have the UTHealth Houston Neuroscience, but to recognize the Ruiz Department of Ophthalmology. So I'm going to now turn the program over to Ann Crocker and ask Ann to help me out with the beginning of the introductions. Thank you all for being here today.
Hi there. Thank you, Elena. My name is Ann Crocker, and I'm the physician liaison here at UT Health Houston for neuroscience and ophthalmology. We are super grateful to have with us today Dr. Wu. He is one of our board certified ophthalmologists, and he's going to teach us the importance about eye health, especially as we age. He's also going to share what to expect as our vision changes, share ways to help preserve eyesight, as well as treatment options available as these changes happen. So, Dr. Wu, thank you for being with us today, and I'll pass it on to you.
Hey, thank you, Anne, for that introduction. You're able to hear me. I just want to check the microphone before I proceed. Okay, perfect.
Yes, yes.
Wonderful. All right. Well, thank you everyone for taking your Thursday afternoon to join me here. I am giving just a quick um, overall sort of umbrella talk about eye health as we age. And we'll touch upon a few topics in detail, but I'll go over most of things that we can expect as we age with our eyes. So without further ado, we will proceed here. So common age-related eye problems that anyone can kind of expect. Um, Dry eyes, very common. Cataract, as long as you make it to a certain age, you'll develop cataracts. It depends from person to person when they become visually impactful, but everyone eventually will develop cataracts. Glaucoma as well is something that occurs more frequently as people age. Presbyopia is a fancy term for when we start to lose our ability to see up close as we get older. People who are maybe around 40, 45 years of age will start to notice this happening. That's when it becomes noticeable. And it kind of gradually progresses over the years as we continue to age. There's also age-related macular degeneration. I'm sure a lot of members in the audience have heard of this before. Also something that occurs as we get older. Diabetic eye disease, more applicable for patients who have a diagnosis of either type 1 or type 2 diabetes. Um, that's not so much related with age, but it does have some correlation there. And then floaters. That also is a very common complaint as we get older. We're going to be focusing on the top three things there. Dry eyes, cataract, and glaucoma. Um, Personally, if this, I'm not sure if this was mentioned before, but I am a cataract and glaucoma specialist, so that's hence why I'm going to be talking about those topics. But I think dry eyes is probably the most common uh, age-related eye problem on this list, and so that is something that I will touch upon as well. So, starting with dry eyes, in the literature, it is reported that it's a pretty widely variable percentage, but it's reported that anywhere from 7 to 33, 34% of the general population it has some degree of dry eyes, whether it be mild or severe. It's usually due to a lack of tear production and or poor tear quality. So a lot of people will they know about the fact that there's not enough tears, but there's actually multiple components to tears, and the health of those tears and the quality of those tears can also play a role, a significant role in dry eyes. Again, the severity can range from mild to visually debilitating. So here I have a nice diagram. I think pictures, when it comes to showing things, I think they're very valuable. So here is a kind of simplified diagram of the anatomy of our tear system. And I'm actually going to pull up a laser pointer here. Hopefully everyone can see this. But here we have the lacrimal gland. This is the tissue and the structure that produces our tears. The I guess the majority of our tears. It produces 80% of the component of the tears, and this is actually covered by our skin, our bones, our brow bones. You won't actually see this structure ever really, but they secrete tears and they kind of lubricate our eyes that way. And then you have these structures here called the meibomian glands. And these are structures in your eyelids. You have them both in the upper and the lower eyelids. There are a bunch of these going across the eyelids. And you can actually see these pores with the naked eye, but these secrete the oil layer of the tears. And this is actually a very important layer as it stabilizes the tear film and it boosts the quality of our tears. The last layer is the mucus layer, also an essential component. This is produced by cells that are located on the surface of your eye over the white part where my laser pointer is showing you right now. And all these components make up our tear film. And so if there's a deficiency in any one of these components, that could cause dry eyes and such. So moving forward from that, okay, let's see. What are some of the symptoms that you can have? It's a pretty wide range. Anything from burning, stinging, itching, tearing actually, believe it or not, a lot of people think it's counterintuitive, which it is, to have tearing if you have dry eyes, but it's a effect we call reflexive tearing. And what happens is your body senses that your body isn't producing enough tears, or the tear quality is poor, and so it tries to compensate and sort of overproduce tears on its own. But these tears are of poor quality, so that it's kind of sort of like a vicious cycle that kind of um, uh, propels on itself. You can have discharge, mucus, redness as well, even eye pain or headache, also known as eye strain. It can also be a symptom of dry eyes. Causes, first and foremost, aging. Also related to the aging, there's changes in hormone levels, that sort of thing. Allergies can play a role, especially as the seasons change here in Houston. We know that allergies typically are a pretty big issue. Um, Eyelid inflammation, certain medications. A lot of people take certain medications for other medical conditions that they might have. Some of the common medicines that do kind of play a role in dry eyes. Any over-the-counter cold medicines, antihistamines, so any thing like Zyrtec, Claritin, all that stuff. Beta blockers, if you have high blood pressure or heart conditions. Some over-the-counter pain relief medicines, sleeping agents, uh, blood pressure medications as well, hormone replacement therapy, so on and so forth. Certain medical conditions also predispose people to developing dry eyes. So if you have any autoimmune conditions, that's a very closely associated group of diseases that can cause dry eyes. Infrequent blinking, if you're staring at a computer screen, reading for a long time, we naturally blink less during those activities. So that also, you might have those symptoms during those activities. Contact lens use, if you've had laser eye surgery, and so on and so forth. I think this is a really good picture diagram of treatment options for dry eyes. And so let me pull up my laser pointer again. If we'll start on the left-hand side, artificial tears. This is the first thing that we recommend for patients to try. Um, that you can get these pretty much over the counter. There are drops that come in bottles, and there are drops that come in the vials. The ones in the vials generally are all preservative free. If you're needing to use these lubrication eye drops more frequently than about 4 or 5 times a day, the recommendation is to go to preservative free. If you're only needing it here and there, twice a day, something like that, the ones that come in the bottle are just fine. I would look for uh, brand names. So for example, Refresh or Sustain are brands that I would recommend. There was that scare, I think, a few years ago with non-brand name lubrication eye drops, artificial tears, and about causing eye infections and things like that. So it's best to probably stick with the brand names here. Also, kind of one of the first things we recommend are the second category here, eyelid hygiene. Warm compresses. They are they can do wonders for you. What this does is it actually helps you release some of the oils to make the oil component of the tear film. It releases those good, healthy oils to help stabilize your tear film and improve quality. There are also eyelid wipes that can clear any crusting, debris, dust, things that are on your eyelashes, eyelids that you would want to wipe away. So these are great as well. These are things that I would recommend as first line therapy as well. Um, Lifestyle changes can always be helpful, although not always conducive to one's lifestyle. So for taking breaks, if if you're someone who works in front of the computer a lot, taking breaks every 1, 2, 3 hours just to rest your eyes, that would help. Um, certain supplements, having a balanced diet is definitely great, but certain supplements such as fish oil can help with improving dry eyes. And then obviously if the heater is on at home or if it's very dry out during the winter time, um, those things can also contribute to dry eyes. And so if any way to combat those, such as indoor humidifiers, avoiding being outside as much as possible when it's colder outside, that would also help. And then you get into the last category on the right-hand side here. These are things that need, prescriptions, or you may need uh, a specialist, for example, so an ophthalmologist, or specifically someone who specializes in advanced dry eyes. They would be the ones who kind of offer these things for you. So there are prescription eye drops that do help with dry eyes, things such as Restasis or Xiidra. Those are the most common ones. There are also punctal plugs. Punctal plugs are little silicone plugs that go into the tear duct where the tears drain. And so if you block the drainage of the tears, you build up tears, and that uh, helps with improving dryness. And then there's also more novel eyelid treatments. One of my partners here in the practice actually does some of this stuff, but these are kind of the latest and greatest. And what they do is they can help with the release of good oils to improve tear quality. There's actually a laser treatment that can help with tear production and tear quality as well. And so those are kind of the more novel options that you would have there. All right, so that is a little bit about dry eyes. Pretty comprehensive overview. We're going to move on to a little bit of a different topic. Vision loss in the elderly. 1% of adults aged 50 to 54 years in the US have some form of visual acuity impairment or are blind. Um, Seems like a small number, but that number actually goes up as the age category goes up. So it gets to be more significant and it compounds each other. There's over 20% of adults aged 85 years or older who have vision loss. So that kind of shows you what that trend looks like. And then 80% of vision impairment and about a quarter of blindness is preventable or treatable. And that is actually the more important thing I think that I want to emphasize is that as we get older, it's very prudent to get eye exams kind of on a routine basis, either yearly or more frequently, if you have some condition that needs to be treated or monitored. Um, Vision loss plays a role in all of these things. So cognitive issues, reduced physical activity, increased falls that leads to fractures, depression, uh, loss of independent living, and even mortality. So uh, that's why it's so important that we look out for our visual health. Um, the American Academy of Ophthalmology, which is kind of our big organization for our specialty, they recommend a comprehensive eye exam every 1 to 2 years for adults 65 or older without any risk factors or other eye conditions. So this, I think, is something to take home. Our second topic of the day is cataracts, also very common. Um, Cataracts, they develop slowly, and there is a very gradual decline in vision. But generally, the vision decline can't be corrected with glasses, and that's sort of an indication of when you would know that you're ready for surgical intervention. Things that you would experience, blurry vision, difficulty reading, especially in dim lighting, poor vision at night, glare with oncoming car headlights or bright street lights, and also loss of contrast. Things, colors don't appear as vivid as they used to. You start to kind of lose the ability to kind of distinguish subtle changes in contrast. About 3 million people in the US undergo cataract surgery each year. It's actually the most common surgery performed in the US year to year. And these are some examples here on the right-hand side that can show you sort of different stages of cataracts. So here is a pretty clear lens. And here, if you see the yellowing here is where the cataract is. So this is about a moderate cataract, and then here is a white cataract, and this is pretty advanced. So no light can get through. You won't be able, it affects the vision, and things are going to be very blurry. This is another diagram to kind of give you an idea of what your vision would look like if you had cataracts. So in a normal eye, on the left-hand side, you can see that the light passes through um, normally, and it focuses on your retina back here where my cursor is, and you get a nice clear picture of everything. But if you do have a cataract, notice how this area where the cataract is very hazy, and when the light comes in, it decreases in intensity and it gets scattered all different ways. And so it doesn't focus on the retina that well, and that prevents you from seeing well. And here is what what your vision might look like in that situation. Notice how everything is a lot fuzzier, dimmer. It's kind of like looking through a plastic bag, so to speak. Risk factors for cataracts. Age is the number one. Diabetes can cause cataracts. Chronic use or long-term use of steroid-based medicines. Um, Smoking, UV exposure. So it's important to kind of wear sunglasses if it's a bright day outside, when you're driving especially. Trauma can cause cataracts, prior eye surgeries, amongst other things. And surgery is the definitive treatment for cataracts. It gets to be a point where glasses can't really correct your vision anymore. And again, that's when you would know when the cataract is likely visually impactful. The surgery itself is very safe. Again, it is the most common surgery performed in the US year to year, and it is an outpatient surgery. Our technology has gotten to be pretty advanced over the last 30, 40 years. So now, cataract surgery has been and will be an outpatient surgery. Um, most, I would say probably 95% of the time, you're gonna have better vision the next day. Some people even have 20/20 vision the next day, which is pretty amazing. Um, to give you an idea of what these implants look like, this is true to size, so a zoomed in magnified picture of a person's finger, and this is the actual size of the implant that goes into the eye once the cataract is removed. And you can see how it is nice and clear. It, again, pretty small. It's got to fit in the space. And it looks like this on the right-hand side once it's in the eye. And these implants are good for life. There's no reason to have to remove them. And once you do your cataract surgery, you're pretty much done in that eye. Just gonna go talk briefly about what the surgery entails. I won't go into any excessive details, but if you can imagine laying down on a bed, and the surgeon is coming in. We have these tiny microscopic uh, knives and blades that we use, and we make basically 1 to 2 millimeter incisions on the surface of your eye. Your eye is going to be numb. Uh, there's going to be numbing medicine that's given to you both locally and through an IV. And we make these tiny incisions and we go in with our instruments and we break up the cataract into tiny pieces. And we leave the structure called the bag, which is where the new implant is going to go. And the implant goes into the eye and sits right in that bag. And there you have it. You're going to have a brand new lens in the eye. The surgery itself takes, someone who's been doing this for at least 5 years or so, surgery is probably going to be about 10, 15 minutes, 20 minutes max per eye. So that is a little bit about cataracts. The last kind of topic that we will touch upon is that of glaucoma. And this is one that I um, also like to emphasize and make a point to talk about because glaucoma is a disease that causes permanent vision loss. So cataracts, it's reversible vision loss, meaning you can treat it, do the surgery, and your vision pretty much improves and returns to normal. But glaucoma is permanent, irreversible vision loss. It is the second leading cause of blindness worldwide. It's an eye disease that causes damage to the optic nerve being the structure that connects the eyes to the brain. And so you can imagine this important structure, if it gets damaged, that does cause problems in the vision. Again, it is progressive and irreversible. There's not necessarily a defined single cause. It's kind of a couple different things that play into it. Uh, there, the only thing that we can really kind of address and control as providers is the pressure of the eye. And so that's why you hear about all these patients who have glaucoma on pressure lowering medicines and such. Other things can also play a role in it, but the main thing is that we can change is pressure. So here's a nice diagram that shows you uh, kind of what glaucoma is. This is a healthy eye on the left side. If you have a normal pressure in the eye, which is anywhere from about 8 to 22 millimeters of mercury, um, you're not going to really have any issues. This is the optic nerve back here. Uh, if you look at this side on the right side with glaucoma, um, pressure buildup causes uh, damage to the optic nerve back here, and we start to lose the nerve cells that are in this optic nerve, and when those get damaged, that's how we lose the vision. Now, why does pressure go up in glaucoma? Um, there is a structure here called the trabecular meshwork, and this is essentially the drainage channel of the eye, and it's all around, it's 360 degrees. You can kind of liken it to having your kitchen sink uh, at home. If the kitchen sink is blocked somewhere down the pipeline, the fluid backs up. And if you can imagine that things were closed off, the pressure would build up as more and more fluid builds up. And so that's essentially, in a nutshell, what's happening in an eye with glaucoma. And I have these diagrams here. This is going to be able to paint a better picture as to what kind of damage glaucoma can cause. And I think these are going to be very enlightening. So you see here, this is what a normal person would see. Roads, cars, and you have children playing off to the side here. As patients develop glaucoma and irreversible vision loss, they start to lose parts of their, we call it the visual field. They start to lose parts of their vision. And it starts in the periphery. So you can imagine how dangerous this could be. Because now this patient here, they can't even see the kids running out to get the ball. If you keep going, it shows you more and more how, as the glaucoma gets more severe, what other parts of the vision that you can lose. And so you might be wondering why patients don't necessarily notice this, and it's because glaucoma moves very slowly. We call glaucoma a 30-year disease because it takes a long time for a patient to perceive any damage or vision loss that's occurred. And that's why screening is so important, is because we can actually catch glaucoma before it becomes visually significant. I have other pictures here to show you what the optic nerve looks like when we look at your eyes. So on the left-hand side here, I have a picture of a donut because these nerves very much look like a donut. This is a healthy nerve on this first set of 3 pictures. And as you see the center get larger, that is consistent with glaucoma. And you can see here, it's basically all the way around. And that on the right-hand side is very, very advanced glaucoma. Here are some more pictures to kind of give you an idea. A normal nerve here on the left, the light is very bright. As that center gets bigger and glaucoma gets worse, the light becomes less bright. And that essentially is what's happening in patients with glaucoma. And it can get to a point where it becomes so advanced, we call it end-stage glaucoma, and to the point where you can't even see anything. It just becomes a very dim curtain kind of covering your eyes at all times. There are different types of glaucoma. Within these categories, there are also subcategories. The most common type is primary open-angle glaucoma, and that's kind of what we'll touch upon a little bit more today. Risk factors for glaucoma include elevated eye pressure, high eye pressure, age, of course. Certain races are more predisposed to certain types of glaucoma. Um, Then nearsightedness, thinner corneas, family history is important. That's also a pretty significant risk factor. If an immediate family member has been diagnosed with glaucoma, it probably is a good idea for other members of the family to go and get screened, or at least an eye exam to check. High blood pressure and diabetes have been described in studies to show an association with glaucoma, but it's not definitive as to the extent of the association. Again, treatment is aimed at lowering eye pressure. It's the only thing that we can really control at this time. Um, there are things such as medications, laser treatments, and also incisional traditional surgery. And we're going to talk a little bit about these. Again, the emphasis here is that early diagnosis is key. Here are some eye drops, medicines that we can use to help lower pressure in the eye. There's about 5 or 6 big categories, um, and all these medicines work in some way, shape, or form to either decrease the amount of fluid that's being produced in the eye or to improve the drainage of the fluid. Here are some diagrams and pictures that show certain laser therapies that can be done to modulate pressure. Uh, Most of these are done in the office, and they're also very safe. It's one of the laser treatments is actually recommended now to be first choice therapy in the treatment of glaucoma. They take probably anywhere from 5 to 15 minutes to do, and it's done in the office. It's technically outpatient, and you get to go home the same day. Here are some pictures that show kind of the latest the latest things to hit glaucoma as a field. These are in a category called minimally invasive glaucoma surgery. And there are a wide variety of different devices that are used. I have a few of them shown here. They're in two separate categories. One's called stenting procedures, and the other is called goniotomy procedures. Goniotomy meaning we kind of strip away tissue in the eye that's causing resistance to outflow of fluid, and that would help better improve um, outward drainage of the fluid. And so these are devices that I have been trained, and my partner here at Cizik has also been trained in. We do these pretty extensively for our patients, and they do tend to work very well. And they kind of serve as a middle ground between using medicines and lasers to lower eye pressure and more of the traditional, more invasive glaucoma surgeries. Again, these are devices that have just come into the field maybe about 5 to 10 years ago, is when they first started, and these are um, pretty revolutionary in our subspecialty. And then the last category here is the traditional glaucoma surgeries. Um, they are typically reserved for patients with more advanced disease. You have two categories, basically. One is called tube shunt surgery, and the other on the right-hand side is called trabeculectomy surgery. Without going into too much detail, tube shunt surgery basically is an implant that we give to the eye, and it has a thin, small tube that connects to where the fluid is in the eye, and it drains to the back of the eye. That does lower pressure. And then the trabeculectomy surgery is where we use the natural tissues of the eye, and we go in and we create a alternate drainage pathway, which allows the fluid to flow from the front to the back of the eye and the body reabsorbs. So those are the traditional glaucoma surgeries there. And that pretty much concludes my talk today. Here are some references that I have included. And here is a slide with the contact info for our office. We have, I want to say we have more than a dozen ophthalmologists here, all of which who do different things. And so you have glaucoma specialists like myself, cataract specialists like myself and my partners. You have retina doctors, plastics specialists, cornea doctors, you name it. So if anyone is looking to get an eye exam, we'd be happy to see you guys here.
Thank you, Dr. Wu. So helpful and super insightful. We did have a few questions come in as you were talking. If you, I'll read them to you. If you want to help answer them and give some feedback to the audience, that would be awesome.
Absolutely.
One of them says they had a doctor say to avoid Visine, Clear Eyes, and Nafcon brand artificial tears because it may make the irritation worse. Is that true?
Definitely true. I tell my patients the exact same thing. The Visine works great if you're looking for a temporary solution to red eyes. But if you use that over a more prolonged period of time, it can start to cause rebound dryness and irritation. So yes, that is true. And generally, we do tell all our patients to avoid Visine.
Thank you. And the next question, it says, is there a medically accepted trigger point for going forward with cataract surgery?
A medically accepted trigger point. I guess they're asking, is there some form of threshold that we're looking for in our exam that would
Correct.
make
Yeah,
okay.
that's what I
So
think so too.
yeah, so yes, there is. It's generally when the vision is not able to be corrected by glasses to better than 20/40, 20/20 being perfect vision. And that is I would say the vast majority of times, that is the trigger point that we're looking for. There are certain other things that play into it. For example, if patients are really symptomatic from driving at night with oncoming headlights and seeing glare and halos, that is something that we would consider pulling the trigger earlier for cataract surgery. As well, there are certain types of glaucoma actually that necessitate earlier removal of the cataract. So, but in the general sense, the vision being 20/40 or worse is what we're looking for.
Okay, next question. Can you do a second cataract surgery if the first one wasn't totally successful? And is it safe?
So, I guess in the sense of it being unsuccessful, maybe the implant that was chosen ends up not being the most ideal, or there are certain maybe issues that the patients are having. In which case, yes, you can kind of do a lens exchange, an implant exchange. But the risks associated with that surgery are a bit higher than the initial cataract surgery. It can be done, it has been done, but generally we try to avoid it if possible.
Thank you. And another cataract question. It says, for the cataract surgery, what is the recovery like? How much time would I be limited in my activities? Good question.
Yeah, that is a great question. We've gotten to a point that the technology is so advanced these days, and the surgeries we are done with minimal energy used, and so the inflammation and such are also minimal after surgery. And so what you're looking at in terms of recovery time for the vision, it might be great vision even on day one after surgery. But if not, generally by the first week, you're going to have 90%, 95% of your recovery done. Also, for in terms of physical activity restrictions and things of that nature, also about a week. So you're looking at essentially at a week of downtime. But again, the vision could be really great even the next day.
Thank you.
Mhm.
The next question says, I currently take latanoprost for glaucoma. Will I be taking this the rest of my life? And also, do I need to keep it in the refrigerator while using it?
You said it was latanoprost?
Yes.
Okay.
Sorry, I probably
Yeah.
mispronounced that.
Oh, no, no, no worries. So yes, latanoprost is a great medicine. Generally, if you've been started on any glaucoma medications, they're probably going to be long term, if not for life. But there are certain other things nowadays that can be done to maybe get you off of the medicine. So, for example, those in-office laser procedures I was talking about, that can be tried, and if the pressure responds well to that, then you might be able to stop the medicine. Also, if you haven't had cataract surgery yet, the minimally invasive glaucoma procedures are usually done at the time of cataract surgery, and those can also help bring the pressure down to a level to where you don't have to use medicines long term. So there are options. It just kind of depends on where you are individually as a patient.
Thank you. And I see that there is a hand raised. If you could put the question in the chat and then we can get it to Dr. Wu that way. Next question says, is there any way we can slow down macular degeneration?
Mm. Studies have shown certain lifestyle modifications that can potentially help. So UV light protection, so wearing sunglasses when you're out on a bright day or driving in bright sunlight. Uh, no smoking cessation, so no tobacco. And consuming green leafy vegetables such as kale and spinach, as well as these vitamins called AREDS2 vitamins, AREDS2. They're over the counter, and they have been shown in studies to slow progression of macular degeneration.
So interesting. Okay, it's very interesting. The last question it looks like we have here is, it says, I hear cataract surgery makes eyes drier. If one has dry eyes to begin with, what do you suggest?
Um, So it is a possibility, yes, that cataract surgery does make eyes drier, but I would say that in the vast majority of patients, it does not become a significant issue. Now, if you have dry eyes as it is before surgery, um, there you might be, using your artificial tears a little bit more frequently afterwards, or there are those other treatments that I mentioned earlier in the presentation that could potentially help mitigate the dryness. But it kind of just depends. There's no way of necessarily telling which patients are going to develop significant dry eyes after cataract surgery or not. But I will say the vast majority of patients do not have an issue with that.
We had one more question sneak in. It says,
Mhm.
is macular degeneration genetic?
It it can be. And I say that because there are patients who develop macular degeneration without a family history. But definitely, if you have a family history, if there's someone, either parents, siblings, grandparents, who do develop macular degeneration or did develop macular degeneration, it is worthwhile to get an eye exam to check and see if you yourself have it or not.
Wow. I really want to thank you, Dr. Wu, for taking the time today to provide this presentation. I also want to thank UTHealth Houston, the Release Department of Ophthalmology. I will be sending a recording to all of you who are on the call today so that you can have the reference, because there was such great information provided. I'm sure that it hit home to you guys. It definitely did to me. So I, again, thank you so much, Dr. Wu, and to Anne for being the moderator. And please look for future Zoom programming. We will be doing this throughout the year for our members, thanks to the generosity of UT Health Houston Neuroscience. So everybody stay safe and have a great day. Bye-bye now.